All right, so tonight we're going to talk about neurological patients or clients that are using and utilizing BFR. I think the big thing is what people want to know is it safe? Can I do this? And can it be safe and effective? This is me. I'm at Cara. I'm the Director of Education for Smart Tools Plus. I've been so for about the last 10 years. I have a private practice in Dallas, Texas, and utilize BFR a lot. It's not my only means of strength and conditioning, but I use it a lot with my rehab patients and those people that cannot lift heavy loads due to either injury or underlying problems or disadvantages. So today what we're going to talk about is what happens in neurological conditions, why traditional rehab typically falls short, how BFR can fit in, and see some applications in stroke, MS, and some other neurological conditions. We'll talk a little bit about safety considerations and some practical protocols. So what really happens in these neurological conditions is that we get this muscle weakness, usually due to inactivity. Some conditions can also reduce motor unit recruitment or impaired coordination, cause rapid muscle atrophy, and it can cause fatigue and decreased endurance. And it's not just the muscles problem, it's also the nervous system's problem. Rapid muscle atrophy may begin within the first week of detraining. I think a lot of people can't have a tough time grasping that, but disuse atrophy happens very, very quickly. So you can work months and months and months on building muscle mass, and then you get injured and you don't use that limb for just a short period of time, and atrophy kicks in. Now, the good thing is muscle has memory, and it usually will fight back quickly, but a lot of people get injured, they stop training, and then they never train again, and that's a problem. I think that traditional rehab has weaknesses because a lot of times people are injured, they can't lift heavy weights. And what we know is that if you can't lift heavy weights or take light weights to failure, you're not going to get strength or muscle mass gains or hypertrophy gains. Like the ACSM recommends high intensity training of at least 70% of your 1 rep max for increasing strength and hypertrophy. A lot of people can't do this due to joint problems or other neurological conditions. So their rehab is usually very, very light loading, which doesn't cause strength and hypertrophy changes that they're looking for. And this is why BFR is a game changer. You can use very light loads, even body weight a lot of times, something between 20 and 30% of your 1 rep max. Use cuffs, and you can get the adaptations that you're looking for while you're using these light loads that are protective of the tissue and of the joints. This study by Vanalo and Gill et al. In 2022 found that BFR in neurological populations improved sensorimotor function, but also performance, like gait performance, muscle thickness, and endurance and fatigue. And there's a reference there below. So it's not just that you can get muscular change, but we also see functional change, meaning improvements in sit to stand, improvements in gait, improvements in a lot of the other things that we would expect to see with regular strength and conditioning. A meta-analysis by Mengeas in 2026 found that combining BFR with neuromuscular electric stimulation may provide a positive hypertrophy stimulus when voluntary movement is limited, supporting BFR's potential role in enhancing neuromuscular input during rehab. So if you can't use that limb, you can do isometrics, or you can do it passively and add e-stim to it to get the muscles to contract. And what Afrin Argun found was that you can actually gain muscle size by doing this. But how BFR works, why it's so magical, is it creates a couple different things. Number one is it creates a metabolic stress. It forces the oxygen reduction into the limb, which forces the local and systemic adaptations that you're looking for from exercise. You also get a cellular swelling and an M2 or C1 pathway synthesis, meaning turning the switch on for muscle cell growth. We get fast twitch fiber recruitment. Fast twitch fibers are the type 2 fibers. Typically with low intensity work, we're only turning on type 1 fibers. Those are oxygen based, but BFR decreases the amount of oxygen, causes premature fatigue, and forces the body to start utilizing these type 2 fibers, which are more apt to increase size and strength. It also appears, according to Lee et al. In 2025, found that one session of low load BFR improved cognitive task performance and increased neurotrophic factors, especially BDNF and VEGF, suggesting a possible role for BFR in supporting neuroplasticity. Meaning that if I'm forcing the peripheral system to increase activation and type 1, type 2, and the multiple types of type 2, we're probably training our brain as well. So you're getting it both from the limb to the brain and from the brain to the limb. I had a patient that had a severed spinal cord injury from he's basically mountain bike riding and crashed. And so we were doing some consulting with him as far as how do we implement BFR while he was trying to maintain his muscle mass as much as possible. And so these incomplete spinal cord injuries are typically characterized by residual sensory and motor function, and lower limb function varies widely. Muscle atrophy is the primary clinical concern. And so you'll get this rapid reduction in muscle mass when you're no longer getting that signaling from the brain because of the incomplete spinal cord injury. Jesperson in 2011 published that atrophy of type 2 fibers can occur only after 5 days. So imagine you're severing the spinal cord, and now that you're not getting any signaling or limited signaling to those extremities, you're going to get atrophy very, very quickly. Staves et al. In 2018 published a paper talking about the safety of the spinal cord injury with no increased cardiovascular strain versus traditional resistance exercise. And it also improved BFR, meaning local blood volume and osmotic pressure gradient favoring cell swelling. So you've got this muscle cell and you're forcing fluid into it because you're using these cuffs to not allow the fluid to leave the limb. And that signaling and that cellular swelling can stimulate that muscle protein synthesis or muscle mass gains. You can do it passively, like if you can't use the limbs at all, or you could do it aerobically, or you could do it actively. In this case, this was a specialized bike that was set up that had electric stim connected to it. And the electric stim was basically turning the muscles on, and then we had BFR going. So that way we were getting this cellular swelling, we were getting this type 1 and type 2 muscle activation primarily through the electric stimulation. And so an example of doing cellular swelling with electrical stimulation would be 80% limb occlusion pressure in the lower extremity. And then you do 5 minutes of inflated BFR with 3 minutes of deflated BFR. And you do a total combination of 5 cycles. Combine this with EMS and those muscles are getting contraction at the same time. You can also do aerobic capacity training, lower extremity, recommending 60% limb occlusion pressure, and you're doing somewhere between 5 and 20 minutes of continuous exercise at 30 to 45% of heart rate reserve. If you're unsure how to get heart rate reserve, you can go back to one of my other lectures on aerobic capacity training where I talk about how to calculate that. Some other cases might be stroke. I know some inpatient physical therapists use BFR with patients that have are in a coma or had a stroke and are bedridden, and they will use BFR passively to try to maintain the muscle mass the best that they can. But you can also utilize this with patients that are recovering from stroke in order to turn back on muscles that have been interrupted. So kind of a stroke protocol might be lower extremity exercises doing in a seated position, like at leg extensions, or you could do sit to stand. Load might be body weight or light resistance. Pressure is 60 to 80% LOP. Protocol usually is going to be somewhere between 30 reps for the first set, and then 15, 15, and 15 with a 30-second interset rest. And then we deflate the cuffs and we move on to the next exercise. We typically will do somewhere between 3 and 5 exercises in a session. Some other cases might be multiple sclerosis, where you get demyelination or slower nerve conduction to the extremities. Fatigue is a primary limitation with muscle weakness and heat sensitivity. BFR can help maintain muscle mass or build muscle mass with lower stress to the system. Here's your MS protocol. You're going to use a little bit lower pressures, 40 to 60% LOP. You might only do 2 or 3 exercises in these cases because of the early fatigue. Always start light and build up. You can always start with just, 1 exercise, 2 exercises, and as they get confidence, you can build up more and more. I got a question. Let's see. Oh, all right. That was Kyla. Okay. Other conditions: Parkinson's, traumatic brain injury, peripheral neuropathy. All these can be utilized with low load stress to the joints and muscle tissue while still getting gains of high intensity exercise. Some safety considerations, especially with our spinal cord injury patients. Autonomic dysreflexia is a potentially life-threatening autonomic nervous system overreaction that can occur in individuals with spinal cord injuries, especially at P6 level or above. Current evidence suggests that BFR does not increase the risk of AD, but we always want to start these folks light and gradually build them up with increases in intensity and increases in duration. From a safety standpoint, there's really no additional stress to the cardiovascular system. Slight increase in blood pressure, but not much, not enough to be clinically significant. So it's very safe, very tolerable, and very clinically beneficial. Some ways to make sure that you are being safe: always measure limb occlusion pressure, start with low pressures and progress gradually. Monitor for pain, dizziness, excessive fatigue. Use simple movements initially, like simple single joint exercises versus compound exercises. Focus on quality of movement, combined with neuro re-education, and start with unilateral training if necessary. So some key takeaways: neurological weakness is not just muscular, it's also a problem of neural activation. BFR helps patients build strength using low loads when heavy training is not tolerated. BFR supports both muscular adaptation and neuromuscular signaling. Passive BFR and BFR with E-stim may help severe cases with limited voluntary movement. Safety comes first. Screen for contraindications, measure LOP, start low, and monitor fatigue. All right, I'm going to take some questions, but next month, we're going to do BFR for return to sport planning. Being registered in my monthly BFR is enough, and you'll get invites to that. Here's my contact information and some references that were used tonight. We do have the BFR Bootcamp. If you need more information about how to get started, it's essentially like a 5-day boot camp where you are able to get up and started very quickly. And then we have BFR professional certifications. This is BFR level 1, BFR level 2, and then I also have an instrument-assisted soft tissue manipulation or mobilization course. Here's where you can get those courses from. It's on the smarttoolsplus.com website under education. And you can always connect with me about different learning opportunities around BFR and other health conditions. We have a couple different cuffs available. This is the Gen 3 cuff where there's a pump and you detach the cord when you are ready to work out. And then this one is app-based, where you're using your phone or iPad or Android tablet to control the cuffs. And then for being here, we offer an educational discount of 10% on anything on the site. So feel free to utilize this anytime. We appreciate you joining and learning more about BFR. So I'm going to stop sharing, see if there's any questions that I can answer.
Are the questions only written, or can I do it?
No, you can ask a question. Go for it.
Do you think um, doing E-stem with a light load and a cuff is overkill? Um, as you know, I have a neuromuscular disorder similar to MS, and
Yeah.
I have neuroplasticity. So sometimes that communication from the brain to the muscle short circuit, traffic.
Yeah.
And I have been using the E-stem to kind of initiate, the brain muscle connection, to activate the muscle a little bit.
Yeah.
I haven't used it, with a light load. I've done the cellular swelling, but I was considering maybe trying it with a light load with the E-stem and the cuff. Is that overkill, do you think?
I don't think it's overkill for you, Martin. I think that getting those muscles activated. Now, I wouldn't on your first session go out and do 5 exercises in the same area.
Right.
Start with one in a body part. But I think it would be very helpful for you to kind of help get that muscle brain connection.
Mhm. Okay. That's what I was hoping you would say. Great.
And I would also probably give yourself a day rest in between, like
Okay.
at least in the beginning, see how you respond soreness
Is
wise and all that.
would you consider upper lower, like
Sure.
upper body one day, lower body
No
the
problem.
next? Okay.
Yeah, when I say rest, I just mean the same body part.
Gotcha. Yeah. Yeah. Oh God, that's what I really wanted to hear. That was my question. You answered a lot of stuff in this. I was really happy.
Oh, good. Thanks for joining as always.
Yes.
Any other questions tonight? You can feel free to just pop on. I don't mind at all. All right, awesome. Well, thank you so much for joining. I'll be back next month on Return to Sport. And in the meantime, have a great Memorial Day. Thank you to all my fellow veterans out there. And I will see you guys soon. Bye for now.
Thank you, Ed.